In this lecture, we'll take a look at food-drug interactions. So let's take a look at our definition for a drug-nutrient interaction. So undesirable or harmful interactions between food and over-the-counter medications, prescribed medications, herbals, botanicals, and or dietary supplements that diminishes, enhances, or alters the effect of nutrients and or medications. And so this comes from a position from back when we were the ADAs to the integration of medical nutrition therapy and pharmacotherapy. Now looking at the subtlety of some of our definitions, so we have drug-nutrient interactions, which include specific changes to the pharmacokinetics of a drug caused by a nutrient or nutrients, or changes to the kinetics of a nutrient caused by a drug. Then we also have food-drug interactions, and so this is the broader term that also includes the effects of a medication on nutrition status. For example, a drug causing a side effect of poor appetite would affect nutrition status. Now again, why is this important? Why are we focusing on this as dietitians? Shouldn't this be the pharmacist's job? And so there's clinical, legal, and economic reasons to recognize and focus on these food-drug interactions. And so we're looking at longer or repeated stays in healthcare facilities. We're looking at the use of multiple drugs increasing in many patients. Deterioration of the patient because of the effects of the disease process. So for example, long-term drug-nutrient interaction of corticosteroids on calcium metabolism, resulting in osteoporosis in patients. Now to give you a little bit of background on medications themselves, so we have the Pure Food and Drug Act of 1906 and the Food, Drug, and Cosmetic Act of 1938, where we began to have governmental regulation for drugs through the Food and Drug Administration, the FDA. Now, what we're looking at is that nowadays, right, and especially with the increased availability of knowledge, so again with good quality, right, research and looking at our symptoms, right, people generally have an idea of when they need to see a doctor. And so the big thing is that, right, 2/3 of doctor's visits include prescriptions, because that's not something you can treat yourself, right? Other things, so for example, if it hurts when I do this with my ankle, it's very easy. You can go online and look at things to do or not do with your ankle. But right, so prescriptions are still having to be prescribed by physicians. Now, 39% of the population takes a prescription drug, and spending on prescription drugs has increased fivefold from 1990 to 2006. Now, part of that is the increase in the number of total prescriptions, and some of that is also, remember, an increase in the cost of individual prescriptions. So some of that's inflation, some of that's increased use. But preventing interactions is part of nutrition assessment and of pharmacotherapy. So again, it's this checks and balances where the pharmacist helps us, we help the pharmacist, and the patient wins. Now the Joint Commission does require monitoring, documentation of patient education for food and drug interactions. So for example, when a patient is started on warfarin, the nurse, the pharmacist, or the dietitian, somebody has to educate that patient on the drug-nutrient interactions and things that can occur. So there's a couple other drugs that are like this where, again, they are required by Joint Commission to show education documentation from one of the departments. Now looking at generic versus name brand drugs. So again, something that we have to remember, and this will make sense as we go through the rest of the lecture, the active ingredients in generic drugs are the same as the brand name drugs. So Tylenol contains acetaminophen, and when you buy generic Target brand acetaminophen, that component is identical. However, they may look different, have different inactive ingredients, including fillers and coloring agents. So this is why you'll see typically the generic has a similar shape and color for brand recognition, but you may notice, for example, Advil actually has a candy coating, whereas generic ibuprofen does not. Because again, the candy coating has nothing to do with the ibuprofen itself. So only the actual active ingredient is identical, but the rest of the ingredients do not have to be the same at all. And we'll talk about some examples as we go through the lecture where that makes a difference. So generic drugs approved by the Food and Drug Administration must meet the same rigid standards of strength, quality, and purity that are applied to brand name drugs. Generic drugs are less expensive because the companies that make them don't need to spend money on drug research and development, clinical trials, marketing, and advertising as do brand name drug manufacturers. So typically what happens is that after the patent has worn out, again, there's really not a lot of profit margin left in the drug, and so anyone can make the drug, and it's, from a comparison standpoint, very cheap. And so we have, for example, Nexium versus esomeprazole, and so we have, again, just the generic, and then we have Coumadin, aka warfarin sodium. And so again, what you'll see is that the person who initially developed the drug, the company, has to recoup their development costs, so they have an increased price. But basically, the FDA has said, and the patent office has said, is that once you've broken even, right, and you've made some profit on this drug, then we share, right, the patent goes public, everyone can now use your process to make the drug, and it's significantly cheaper for other people to produce. Now, food and drug interactions can be divided into two broad types. So we have pharmacodynamic interactions, which affect the pharmacological action of the drug, and pharmacokinetic interactions, which affect the movement of the drug into, around, or out of the body. So pharmacodynamics is the study of biochemical and physiological effects of a drug, and pharmacokinetics is the study of the time course of a drug in the body, involving the absorption, distribution, metabolism, and excretion of the drug. Now let's take a look at some drug mechanisms. And so again, these are broad categories. These are not individual drugs. So drugs bind to specific receptors on the cell, which initiates typically an enzyme reaction. Now again, remember that the same way that enzymes digest specific molecules or facilitate specific reactions, these drugs facilitate specific reactions in a similar lock and key model, which is a specific drug affects a specific receptor, which causes a specific reaction. But most drugs interact with more than one cell receptor, and this is how we get side effects, where again, because of these similarities and the number of receptor sites, where again we may get additional unwanted effects. Now drugs cause an alteration in the enzyme system either by stimulating it, aka induction, or inhibiting it. So for example, an ACE inhibitor. So here we can see, again, the lock and key model. So we have a triangle-shaped drug and a square receptor. So the triangle-shaped drug will not activate the square receptors, but the triangle-shaped drug will activate the triangle-shaped receptors. Now what you may have, though, is, and this is a very crude example, but you also may have a receptor site that is a diamond shape, and all of a sudden the triangle-shaped drug fits close enough that it still stimulates this diamond-shaped receptor. And again, as we discussed on the previous slides, we have our side effects. So looking at nutrition complications secondary to pharmacotherapy, so common side effects of many drugs that can dramatically affect nutrition intake include nausea, vomiting, diarrhea, constipation, increased appetite, decreased appetite, altered taste, smell, and saliva production, and weight gain or weight loss. And this can be through, again, the appetite changes, or this can be fluid shifts. Now looking at the route of administration, so again we will see that different drugs can be administered in different ways, and this causes changes in their effects and side effects. So the routes can depend on the chemical properties of the drug, the type of desired effect of the drug, or patient characteristics. For example, can the patient even swallow medications? If not, we really shouldn't be giving them pills, should we? Are they intubated, in which case they have a breathing tube inserted and they obviously cannot swallow pills? Do they have a feeding tube, in which case we could use a liquid form of the drug through the feeding tube, etc., etc. So looking at our routes, so for example, we have sublingual, so under the tongue. For example, nitroglycerin. We have buccal, where the drug is placed in the cheek. This is things like fentanyl or Actique. And then the parenteral routes, which requires an injection, we have things like sub-Q, which is under the skin, intradermal, which is under the outermost layer of skin, intramuscular, which goes into the muscle, intraperitoneal, so in the peritoneal cavity, and intravenous, into the vein. But again, these are obviously all using syringes. We also have topical, so for example, things that are applied to the skin or mucous membranes. Inhalation, so again, this can act locally or have systemic effects. For example, your albuterol inhalers looking at inflammation. Or directly to the target tissue, such as ophthalmic, so again, we have our eye drops, otic with our eardrops, into the epidural space in a specific portion of the spinal fluid, and intrathecal, which again is another space around the central nervous system. But again, this is so into a specific membrane. So again, we're looking at very, very small delineations for very specific drugs. Now looking at drug absorption. So absorption is the process of movement of the drug from the site of administration to the bloodstream. Now we know that food components, and nutrition supplements can reduce the absorption of a drug that is administered orally, and they are dosed accordingly. So when we give you an amount of drug orally, we know that you won't get it all. Now looking at the bioavailability, so this is the fraction of an administered drug that reaches systemic circulation. So we know when we give you a drug that you will not get all of it, except, for example, if we give you an IV drug, we know you will absorb all of it. And so what we need to take into account then is that you will see a significantly lower dose for IV drugs compared to the exact same drug given orally. Now to give you some examples, we'll take a look at absorption for iron. So iron is poorly absorbed when taken with food, and so it's best absorbed when taken on an empty stomach with water or with orange juice. And so we'll talk about that a couple next bullet points. So iron absorption is decreased by bran, eggs, high phytate foods, fiber supplements, tea, coffee, dairy products, and calcium supplements. And we can further increase absorption with vitamin C. So you may see that it is recommended to take iron with orange juice. The only problem is that iron on an empty stomach and orange juice on an empty stomach are both known for causing upset stomach. Combining the two results in, of course, then even more significantly upset stomach and has poor patient compliance, although it does improve absorption. Now we also have to take a look at what's known as adsorption. So this is not absorption with a B, but adsorption with a D. And this is the adhesion to food or a food component, which may slow or decrease drug absorption. For example, the antidepressant Elavil adsorbs to fiber, which causes a loss of the therapeutic effect of the drug. So the drug is now, in essence, glued to the fiber, and the drug cannot be metabolized, digested, absorbed, and then metabolized for its therapeutic effect. We also have to consider gastric pH. So achlorhydria or hypochlorhydria may reduce drug absorption. For example, the drug Nizoral is given to HIV patients to clear candida infections, but it requires an acidic medium for optimal absorption, and HIV patients commonly have achlorhydria. Achlorhydria is also a concern in those taking chronic acid suppressants, such as your Prilosec, Nexium, etc. Looking at medications and enteral nutrition interactions. So liquid medications mixed with enteral formula can cause physical incompatibilities, including granulation, gel formation, and separation of enteral nutrition product. We can also have clogged feeding tubes, which can cause an interruption in nutrient delivery and possibly may even require the tube to be replaced. Now we have so give you an example of some specific liquid medications. This is things like Cipro suspension, Reglan syrup, and Robitussin syrup. The bioavailability of phenytoin, or Dilantin, is reduced when given during continuous tube feeding. So we will discuss enteral nutrition and tube feedings in later chapters, where again, normally a patient would be receiving enteral nutrition 24 hours a day. If a patient is receiving Dilantin, we need to make sure that they have an empty stomach. To do this, we have to turn off the tube feeding for an hour, allow it to exit the pyloric sphincter and exit the stomach, give the patient the medication, allow the medication to be digested and exit the stomach from the pyloric sphincter, which takes about an hour, and then we can restart the tube feeding. So looking at our ASPEN guidelines for medications and tube feedings. So again, remember ASPEN is the expert on tube feeding and IV feedings, so they don't really deal with literally anything else. So this is the only thing they're the experts on, but they're really, really big experts on IVs and feeding tubes. So do not add medication directly to the tube feed. So if somebody's going to get 1 liter of formula, you don't just mix the drug into the formula, shake it up, and try and create super formulas. We do them separately. Avoid mixing together medications that are intended to be administered through an enteral tube. Medications can be given sequentially, but not mixed. So if a patient needs 5 medications, we don't mix them up and create a super cocktail, shake them all up, and then put them through the tube. You give 1 medication, flush the tube with water to clean it out. Give a second medication, flush the tube with water to clean it out. Give a third medication, flush the tube with water to clean it out, and so on and so forth. Liquid medication formulations should be used when available. Now again, this is a cost and availability issue. You will notice that nursing stations have what's known as a silent night, which is, you are probably familiar with a mortar and pestle, right? This is the stone bowl, right? And then, right, so the mortar and pestle, so you can actually grind medications or grind things into a powder. Those create a lot of noise. So there's a specialty version that you will find at nursing stations that are designed for crushing medications. So they can be given in applesauce orally, or they can be mixed with liquids, specifically water, and be given down the tube. But preferably, we would just use a liquid medication from the start, as it's designed to be in a liquid form. Not all medications dissolve well without other additives. The enteral tube should be flushed with water before and after each medication to ensure the tube is cleaned and not clogged. And we want to make sure that we are restarting the feeding after administering the medication to avoid compromising nutrition status. Right, so there's only 1 lumen into the tube, so when you disconnect it to put medication in it, you have to reconnect it. Many times the nurse will say, "Oh, I forgot," and the patient has now gone several hours without eating. And consult a pharmacist for patients receiving co-administered medication with enteral nutrition. So if we do have to give things at the same time, do we have to worry about things being in the stomach at the same time? As we discussed on the previous slide, this is things like Dilantin. Now let's take a look at drug distribution. So distribution occurs when the drug leaves systemic circulation and travels to various regions of the body. So how is it distributed throughout the body? So body areas of distribution vary with different drugs, depending on the drug's chemistry and the ability to cross biological membranes. They can also depend on the rate and extent of blood flow to the organ or tissue, and so this will affect the amount of drug that reaches the area. And many drugs are bound to proteins, where only the unbound fraction is able to produce an effect at the target organ. And again, as we will discuss in some future examples, this will determine dosage. Does dosage need to be changed during malnutrition, etc. So for example, albumin is the most important drug-binding protein in the blood. So if albumin is low, there will be fewer binding sites for highly protein-bound drugs. Now again, we said that the unbound portion of the drug is the drug that works on the body. So if you have low albumin, this results in a larger unbound or free fraction of the drug in your system. So patients with albumin levels less than 3 grams per deciliter are at an increased risk for adverse effects of highly protein-bound drugs. So because the drug has no protein to bind within the blood, the drug will work too well or will cause additional side effects. So the patients would need a lower dose. For example, the drug warfarin is 99.9% serum protein bound, and phenytoin is 90% protein bound. So warfarin, in essence, right, has a very, very strong relationship, incredibly strong relationship with albumin. phenytoin still a very strong relationship with albumin. So we know that the greater the amount of the drug that binds to another substance, the smaller the amount of active or free drug within circulatory or storage tissue. So taking a look at drug metabolism. So the drug is eliminated from the body as either the unchanged drug or as a metabolite of the original compound. And so we have what's known as biotransformation, which is a modification of a drug through metabolism, which renders it inactive for excretion, typically via urine or bile. Now the liver is our major site for biotransformation, or again, you might see the term, right, quote unquote, detoxification, right? This is how we're actually changing the structure of something. Now this is typically done with the cytochrome P450 enzyme system. And so these are the enzymes that are commonly responsible for metabolizing drugs. And food or supplements can either induce or inhibit the activity of this enzyme system, which significantly changes the rate or extent of drug metabolism. Now, a substance may interact with the cytochrome P450 enzymes as an inhibitor or an inducer. So an inhibitor reacts with the specific enzyme by competition for the receptor sites, decreasing metabolism and increasing the drug's effect. An inducer stimulates synthesis of the enzyme system, increasing metabolism of the drug and decreasing the drug's effect. Now, of course, one of the most famous examples of this is grapefruit juice. So grapefruit juice contains a substance that can inhibit intestinal metabolism of some drugs, such as calcium channel blockers and statins like Zocor. Grapefruit juice inhibits the cytochrome P450 enzyme system, which is responsible for metabolism of many orally administered drugs. Grapefruit juice reduces normal metabolism of the drug, which in turn causes increased amounts of unmetabolized drug to build up in the blood, causing greater pharmacological effect and possible toxicity. Now, grapefruit juice gets the most publicity. That's probably because of its popularity with the elder population. But again, that's not the only citrus fruit. So you also have Seville oranges, pomelos, and tangelos also produce the same effect. Due to these serious side effects, grapefruit juice is typically not available in many acute care settings, so we just won't even carry it in the hospital to make sure that a patient doesn't receive it accidentally. Or, for example, go to the cafeteria and try and purchase it themselves, even though it was never intended to be used with hospitalized patients. Now, something else to consider with our drug metabolisms is the therapeutic levels. So therapeutic levels of a drug are determined by measuring blood levels in order to establish the correct effective dose for an individual. So we have what's known as the therapeutic window. And so this is the dosage range with the therapeutic efficacy, so it works therapeutically. If below that window, it may not be effective, and if above that window, it may be toxic. Now, ideally, we like drugs that have large therapeutic windows, aka it's very hard to get the drug wrong, right? Either it will have no effect, but it's very unlikely to be toxic. But some drugs have very, very narrow therapeutic windows. Now, for example, you may have seen this is why with Tylenol, right, they say not to take more than 8 Tylenol in a single day. And so that tells you, right, the therapeutic window, anything more than 4 grams of Tylenol per day, right, can be very dangerous for your liver. So again, here we have this window where again we're looking at as we increase our dose and we have our therapeutic response. And so here we have a fairly large window where again we're not toxic, but the drug actually still works. Now again, we've talked about metabolism of the drug, so how do we actually excrete the drug once we've broken it down? So excretion via the renal system is the major route for the elimination for drugs and metabolites, which is of course why when you have to pass a drug test, they test your urine. But we know this isn't the only route of excretion, and they may also be eliminated via feces, bile, lungs, breast milk, and other bodily fluids. This is why, for example, you may also see drug tests, for example, can measure hair samples, because of course, right, urine isn't the only route, just the most common. So looking at a concept though known as tubular resorption. So this occurs when drugs have reached the renal tubule, but they actually pass back into the bloodstream. So they should have been excreted via the urine, but instead, because of renal dysfunction, there's something wrong with the patient's kidneys, the drug actually goes back into the bloodstream. And so patients with renal disease are going to need an adjustment on their drug dosages. So here's an example. This is the drug lithium. So resorption of lithium, which is an anti-manic drug, so you may have heard about, right? This is the famous song by Nirvana, right? Is lithium. And this is closely associated with the resorption of sodium. So when we provide people with the drug lithium, it's actually a lithium salt. It's not actually metallic lithium. So when sodium intake is low, or a patient is dehydrated, their kidneys will resorb or pull back in more sodium. If a patient is receiving lithium, the kidneys will also pull back in the lithium as well as the sodium under these conditions. Remember, that was being dehydrated or low salt intake. Higher lithium levels, though, can result in toxicity. Likewise, when excessive sodium is ingested, so somebody went to a movies, ate a bunch of salty popcorn, the kidneys eliminate more sodium in the urine and also more lithium in the urine, resulting in lower lithium levels and possibly therapeutic failure, or the drug doesn't work well enough. Looking at a change in pH, so this can cause an increase or decrease in the amount of drug available for tubular resorption. So for example, milk and most fruits, with the exception of citrus, and most vegetables are urinary alkalizers. And so for example, excretion of the drug Namenda, which is an anti-dementia drug, is decreased by alkaline pH, thus raising blood levels and reaching toxic amounts. We can take a look at, for example, licorice. So natural licorice contains glyceric acid, which can cause an increase in cortisol concentration. This results in pseudo-hyperaldosteronism with an increase in sodium resorption, water retention, increased blood pressure, and increased excretion of potassium. And this only requires about 2 twists of natural licorice, or about 100 grams, for this effect to occur. Now, risk factors for drug-nutrient interactions as a whole include polypharmacy, or taking more than 5 drugs or more, nutrition status, genetics, underlying illness, following special diets, supplements, tube feeding, herbal or phytonutrient products, alcohol intake, drugs of abuse, non-nutrients in food, inactive substances in drugs or food, allergies or intolerances, poor compliance, and drug-induced malnutrition. So again, we said that polypharmacy is taking 5 or more medications, and older patients are more likely to take multiple drugs, including both prescription and over-the-counter, and older patients are at risk for impaired kidney function, dehydration, and malnutrition. Now, we do have what's known as the Beers criteria, which is specifically looking at medications in the elderly and their appropriateness. And so we do need, again, the interdisciplinary team. It's important that they coordinate the medication regimen. And again, this is one of the biggest concerns with the number of specialists in the U.S. healthcare system, which is if you go to a specialist and you do not sign the waiver to provide the information to your primary care provider, what happens is you have high blood pressure. Your primary care provider notices you have high blood pressure and they prescribe drug A. You go to your cardiologist, who doesn't realize you're already on drug A. They see that you have high blood pressure and they prescribe drug B. You now take both drugs A and B together when you didn't need to. So again, it's important, right, that the team, right, has all of the information, right, and knows what you're taking to make sure there's no interactions. And so again, this is most commonly in the elderly, and this is why you'll see it's often recommended that we just say, just bring in all of your medications. We can check dates, dosages, duplicates, etc. And I have literally seen patients bring in 2 grocery bags full of medications. And again, sometimes they're duplicates, sometimes they're hoarding the medication, they're only taking the medication every other day, and all kinds of other issues. So looking at risk factors, so again, we have altered GI absorption. So simultaneous consumption with food can affect absorption. So as we discussed previously, iron is poorly absorbed with food. Vomiting and diarrhea can reduce available time for solubility and dissolution. So I once had a patient who had, they had a hyperactive bowel sounds, and so they were having some severe GI issues, to the point where we could literally give them medication, and 20 minutes later you could observe the exact same pill in the toilet. And of course, then, that drug doesn't work or do anything for the patient therapeutically. Now, diseases can interrupt the transit time or surface area. So, for example, Crohn's disease, celiac disease, and cancer, right? If there's actually a change to the structure of the GI tract, this will affect where and how much of the drug can be absorbed. Or there can be a competition for carriers. So, for example, levodopa binds to amino acids, which again then decreases the amount of levodopa absorbed. Other things to consider, for example, body composition. So fat-soluble drugs like Valium can accumulate in adipose tissue, causing prolonged clearance and increased toxicity. Low albumin levels can affect protein binding and drug distribution, as we've discussed previously. And other concerns include the developing fetus, and we know that infants and pregnant women are at high risk for drug-nutrient interactions, which is why you'll see we very, very rarely recommend medications as a in the healthcare setting, or there's a very, very small list of drugs that are known to be safe. Let's take a look at some pharmacogenomics. So this is the science concerned with ways to compensate for genetic differences in patients which cause varied responses to a single drug. So gene-nutrient interactions can affect a drug's effectiveness, and the efficacy and safety of drugs varies according to race and genetic variants. To give you an example, slow acetylators are individuals who metabolize amines, hydrazines, and sulfonamides more slowly than average due to inherited lower levels of the hepatic enzyme acetyltransferase. For example, INH is a drug used to treat tuberculosis. The half-life of INH in slow acetylators is 3 hours, but the half-life of INH in fast acetylators is 70 minutes. The drug dose for fast acetylators can be toxic for a slow acetylator. Looking at nutrient absorption, medications can decrease or prevent nutrient absorption. Chelation reactions between medications and minerals reduces the amount of mineral available for absorption and can also make the drug unabsorbable. So again, remember that chelation is the binding of a nutrient or food component with a drug. For example, Cipro chelates calcium found in supplements and dairy products. Adsorption can decrease nutrient absorption as well. For example, the drug cholestyramine or Questrin, which is an antidiarrheal, adsorbs fat-soluble vitamins A, D, E, and K. So vitamin supplementation is recommended if taking cholestyramine for long periods of time. Drugs can also influence the transit time of food and nutrients in the gut. For example, laxatives reduce transit time and may cause diarrhea, leading to calcium and potassium losses. An altered GI environment can prevent nutrient absorption. For example, H2 receptor antagonists such as Pepcid or Zantac and proton pump inhibitors such as Prilosec or Nexium are used to treat GERD and act by inhibiting gastric acid secretion and raise gastric pH, or making it more alkaline. This may impair absorption of B12 by reducing cleavage from its dietary sources, and Tagamet reduces intrinsic factor secretion. Drugs may damage intestinal mucosa, resulting in nutrient malabsorption, especially of iron and calcium. For example, NSAIDs, chemotherapeutic agents, long-term antibiotic therapy may all cause colitis, bloody diarrhea, weight loss, and iron deficiency anemia. Looking at nutrient metabolism, a drug may increase metabolism of a nutrient, causing it to pass through the body faster, resulting in higher requirements. For example, phenobarbital and phenytoin, which are anticonvulsants, induce hepatic enzymes and increase metabolism of vitamins D, K, and folic acid. So patients may need a supplement of these vitamins while taking these drugs. Or a drug may cause vitamin antagonism by blocking conversion of a vitamin to the active form. For example, Tegretol affects the metabolism of biotin, vitamin D, and folic acid, leading to possible depletion. And so the measurement of levels of vitamins and supplementation of vitamins is recommended. The anti-TB drug, INH, blocks the conversion of pyridoxine, B6, to its active form, which we know that deficiency can cause peripheral neuropathy. Pyridoxine supplementation is recommended while taking INH. To give you some other examples or some other more famous drugs, so Methotrexate. So Methotrexate is a folic acid antagonist used to treat cancer and rheumatoid arthritis. And Methotrexate binds to dihydrofolate reductase, thus preventing the conversion of folate to its active form. And we know that without folic acid, DNA synthesis is inhibited, cell replication stops, and megaloblastic anemia can occur. Leucovorin, or folinic acid, is used with methotrexate and other folic acid antagonists to prevent anemia and GI damage, as it does not require reduction by dihydrofolate reductase. Looking, for example, at statins, or HMG-CoA reductase inhibitors, such as Lipitor or Zocor, affect formation of coenzyme Q10, which is needed for ATP production. When HMG-CoA reductase is inhibited by statins, the production of cholesterol is significantly decreased. Thus, the production of coenzyme Q10 is also decreased. So patients taking an HMG-CoA reductase inhibitor may benefit from at least 100 milligrams of CoQ10 daily for a preventative effect. Taking a look at diuretics, some drugs can increase or decrease urinary excretion of nutrients by interfering with nutrient resorption by the kidneys. For example, loop diuretics, such as Lasix or Bumex, increase excretion of potassium as well as mag, sodium, chloride, and calcium. These are known as potassium wasting diuretics. Potassium supplements are routinely prescribed with loop diuretics, but also need to consider the supplement of magnesium and calcium, especially with long-term drug use. It's important to monitor lab values regularly to make sure these dosages of supplements are correct. On the flip side, we have thiazide diuretics, such as hydrochlorothiazide. These increase the excretion of potassium and mag, but reduce excretion of calcium by enhancing renal resorption of calcium. So we would actually want to avoid calcium supplementation with thiazides. There are also potassium-sparing diuretics, such as aldactone. These increase the excretion of sodium, chloride, and calcium, but spare potassium. So in this case, we actually need to avoid supplementing potassium. And you can see why, again, this can be very confusing for patients because to them, these are all Lasix and they all make you pee. But they work a little bit differently, and so the micronutrient supplementation is different. Looking, for example, at corticosteroids, such as prednisone, these decrease sodium excretion, resulting in sodium and water retention, and they enhance the excretion of potassium and calcium. So we recommend a low sodium, high potassium diet. And calcium with vitamin D supplementation is also recommended if on long-term steroid therapy. Also, there are the known side effects of increased appetite, hyperglycemia due to insulin resistance, and weight gain. Looking at nutrient excretion, we also have other examples such as thorazine, which is an antipsychotic, which increases the excretion of riboflavin and can lead to riboflavin deficiency if the patient also has poor dietary intake of riboflavin. Or for example with cisplatin, which is a chemotherapy agent, can cause hypomagnesemia. And so mag supplementation, either IV or orally, is given between chemo courses to prevent depletion. Looking at the modification of drug action by food and nutrients. So food or nutrients can alter the intended pharmacologic action of a medication by enhancing the medication effects or by opposing it. For example, MAOIs such as Nardil prevent the breakdown of tyramine and other pressor agents including dopamine and histamine. Tyramine is a vasoconstrictor that raises blood pressure, so we want to avoid ingesting foods high in tyramine while on MAOIs, as these can cause dangerously increased rates in the heart, leading to stroke and death. And here you can see a list of foods that need to be avoided, that are medium in tyramine and low in tyramine. And the easiest way to envision it is that it's old stinky stuff. So this is going to be your aged cheeses, aged meats, sausages, soy sauce, fermented soy, miso, sauerkraut, beer, etc. Right, those are going to be your foods that are going to be highest in tyramine, and again, the most risk for causing this dangerous interaction. Looking at caffeine, caffeine can increase the adverse effects of stimulant drugs, such as amphetamines like Ritalin, causing nervousness, insomnia, and tremors, and conversely can counteract the anti-anxiety effect of tranquilizers, such as Ativan. Warfarin, or Coumadin, is an anticoagulant that reduces hepatic production of 4 different vitamin K-dependent clotting factors by inhibiting the conversion of vitamin K to a usable form. Ingestion of vitamin K will oppose the action of warfarin and allow for the production of more clotting factors. To achieve an optimal level of anticoagulation, a balance must be maintained between the dose of warfarin and the intake of vitamin K. So looking at this from an MNT standpoint, we should include education of high vitamin K foods with an emphasis on maintaining consistent intake. So again, the medication dosage can be adjusted as long as the patient has a consistent intake of specific foods. Substances may enhance the anticoagulant effects of warfarin, including onions, garlic, quinine, papaya, mango, and vitamin E supplements greater than 400 international units. And avocados may counteract the effect of warfarin. Again, this is only relatively new because of the sudden increase in avocado intake in the population that we're studying and learning more about this. Looking at herbal products, St. John's wort counteracts the effects of warfarin, and Dong Quai enhances the effects of warfarin. There is concern about cranberry and warfarin by the FDA, but currently we have no evidence-based research to support this. Looking at alcohol, ethanol combined with certain medications produces additive toxicity affecting various organs and systems, and ethanol combined with central nervous system depressant medications, for example Valium, may produce excessive drowsiness, incoordination, and other signs of central nervous system depression. Combining ethanol with NSAIDs may increase the risk of GI ulcerations and bleeding. Ethanol has hepatotoxic potential and should not be combined with medications that also exhibit a risk of hepatotoxicity. For example, we all know not to combine alcohol with Tylenol, but this includes other drugs like Methotrexate. Ethanol can inhibit gluconeogenesis, which can prolong a hypoglycemic episode caused by insulin or an oral hypoglycemic agent such as glyburide. Sometimes we purposely want to elicit this type of interaction. So for example, the combination of ethanol with disulfiram, which is the drug known as antabuse, is potentially life-threatening. Disulfiram inhibits aldehyde dehydrogenase, which is an enzyme necessary for normal catabolism of ethanol by the liver. So with high levels of acetaldehyde accumulating in the blood as a result. This causes unpleasant symptoms including nausea, flushing, headache to appear within 15 minutes of ingestion of alcohol. So when someone is trying to stop consuming alcohol, they will purposely take disulfiram as a way to discourage themselves and create a negative feedback loop, so that if they ever do consume alcohol, they become immediately ill and in theory would stop consuming alcohol. So looking at the effects of drugs on nutrition status, the desired effects of medication are often accompanied by undesirable effects called side effects. Side effects are often an extension of the desired effects, such as bacterial overgrowth as a result of an antibiotic. Nutrition-related side effects can involve oral, taste, smell, GI, appetite, organ toxicity, and altered glucose levels. For example, with oral taste and smell, we have dysgeusia, which is an alteration in taste sensation, hypogeusia, which is just reduced acuity, so one is a change, that's the dys or altered, and then the hypo is the less or reduced sensation. Underlying zinc deficiency may also affect the senses of taste, and as we've discussed, some of these drugs may deplete or compete with zinc. So examples, things like captopril, which is an antihypertensive, can cause a metallic or salty taste to all foods. Biaxin, an antibiotic therapy, can cause things to have a bitter taste. And the sleep aid Lunesta, 34% of patients report metallic tastes. Antineoplastic drugs, or chemotherapy agents, can affect the cells that reproduce rapidly, usually focused on the mucous membranes. These can cause side effects such as stomatitis, which is inflammation of the mouth, glossitis, which is inflammation of the tongue, cheilitis, which is lip inflammation with cracking, and mucositis, which is inflammation of the mucous membranes, anywhere from mouth to anus. Looking at other effects, we have anticholinergic drugs, which compete with the neurotransmitter acetylcholine for its receptor sites, which inhibits the transmission of parasympathetic nerve impulses, resulting in decreased secretions, including saliva, xerostomia or dry mouth, and for example, antihistamines like Benadryl, tricyclic depressants like Elavil, and bladder control agents like Ditropan can have these side effects. Now, for example, sometimes this is done on purpose, so anticholinergic drugs are used during surgery to reduce secretions so that someone does not accidentally, in essence, choke on their own fluids. Looking at other side effects, we have alendronate, which is an anti-osteoporosis drug, which can cause esophagitis if the patient is unable to sit upright for 30 minutes after taking it. NSAIDs can cause stomach irritation, dyspepsia, which is heartburn, gastritis, ulcerations, and gastric bleeding. SSRIs like Prozac can cause serious gastric irritation. And antineoplastic drugs, again we discussed, can have side effects such as nausea and vomiting, dehydration, electrolyte imbalances, weight loss, and malnutrition. And so Zofran, which is an antiemetic, is used to treat the nausea or the side effects of chemotherapy or antineoplastic drugs. Narcotics cause a decrease in smooth muscle tone of the intestinal muscle wall, which decreases peristalsis and causes constipation. Orlistat reduces fat absorption by binding to lipase in the intestine, thereby inhibiting its action. So fat excretion is increased. There's increased fecal urgency and possibly fecal incontinence. The potential for malabsorption of fat-soluble vitamins. But again, this is done intentionally. Again, this is a weight loss drug. Antibiotics, again, destroy all sensitive bacteria of the gut flora, so this can also result in diarrhea. Again, remember that if an antibiotic is looking for example, gram-negative bacteria, it will affect all of them, good and bad, not just some of them. Looking at side effects on appetite, so drugs can suppress or stimulate appetite. For example, dexedrine suppresses appetite. Central nervous system stimulants like Ritalin and Adderall suppress appetite with a common side effect of weight loss. Sibutramine or Meridia and phentermine are appetite suppressants. But the other major side effect of stimulant-based drugs is they can also result in hypertension. Antipsychotic drugs like Zyprexa and antidepressants Elavil can cause an increase in appetite and corresponding weight gain. Corticosteroids can cause fluid retention and increased appetite, again causing a combination of fluid as well as tissue weight gain. But appetite stimulants may be prescribed for patients suffering from wasting diseases such as HIV and cancer, and these will increase appetite intentionally. These are things like Megace, Remeron, Periactin, Marinol, etc. Looking at organ system toxicity, so drugs can cause hepatotoxicity or liver toxicity, such as statins, methotrexate, or Tegretol, or kidney or nephrotoxicity, such as cisplatin, gentamicin, and methotrexate. And there are also drugs, of course, that have pulmonary or lung toxicity, neurotoxicity, pancreatitis, or cardio or heart toxicity. Looking at glucose levels, we've alluded to this previously, but many drugs can cause hyperglycemia or hypoglycemia. So drugs may stimulate glucose production, impair glucose uptake, inhibit insulin secretion, decrease insulin sensitivity, or increase insulin clearance. And corticosteroids increase gluconeogenesis, but also cause insulin resistance and therefore inhibit glucose uptake. And the antipsychotics, for example, Zyprexa and Clozaril, may cause hyperglycemia. So one other thing that we need to discuss with drugs is excipients. So an excipient is an inactive ingredient added to drug formulations for actions as a buffer, filler, dilutant, disintegrant, glidant, flavoring, dye, preservative, suspending agent, or coating. Now these may have interactions in individuals with allergies or enzyme deficiency. So for example, lactose is commonly used as a filler in pills and may cause issues in patients with lactose intolerance. Other examples include gluten, peanut oil, calcium, soybean oil, and egg. So I can give you an example. So I forget the name of it, but there is an inhaler, and these often have drying agents. And so, for example, the different types of drying agents include both corn-based and wheat-based. Well, of course, you breathe this in. So if you are allergic to wheat or you have a gluten allergy, you have to buy the brand that uses a corn-based drying agent. But if you're allergic to corn, then you have to buy the product with the wheat-based drying agent. And again, so this is one of the few times where name brand matters because the drug isn't different, but they will have different excipients. Taking a look at Diprivan or propofol. So this is a sedative for patients in the ICU, and this drug is emulsified in soybean oil. So again, it shouldn't have an allergy if it's pure enough, but again, something to consider. But then also from a nutrition standpoint, something that we need to consider about propofol is that because it has soybean oil used to emulsify it, it does have 1.1 calories per milliliter, which can provide a substantial amount of calories and total amount of fat. So we would need to then adjust the amount of fat intake from the rest of the diet, or in this case, parenteral nutrition. So MNT for drug-nutrient interactions. So if we want to be proactive and warn patients, or in essence provide them information ahead of time, we have prospective MNT. So this is providing basic information about the drug, specific foods and beverages to avoid, possible side effects to be aware of, and warning of potential nutrition problems. Retrospective MNT is focused on evaluating symptoms to determine if medical problems might be the result of a food-drug interaction. A nutrition therapist then would be assessing, intervening, and evaluating drug and nutrient mixtures, right? And so what we really need to take into account is that it doesn't always explain all of the problems, but again, especially the more drugs a patient is taking, the more likely that it could be one of these interactions. So let's take a look at some practice questions. So the presence of food and nutrients in the stomach or intestinal tract generally tends to blank drug absorption. And this is answer choice B, reduce. Number 2, ingestion of grapefruit and grapefruit juice inhibits the cytochrome P450, technically the 3A4 enzyme system, and may, and this is answer choice A, increase blood levels and pharmacological effects of some drugs. Number 3, patients who are taking corticosteroids should eat a diet that is and this is answer choice B, low in sodium and high in potassium. Anti-neoplastic drugs have the greatest effects on and this is answer choice B, cells that reproduce rapidly. And number 5, patients who are taking warfarin should ensure that their diet contains consistent amounts of vitamin. And this is answer choice D, vitamin K. Thank you for your time, and I look forward to your questions.